Hello and welcome to another episode of Everything Digital Health. I'm Marcus Bohr, and today I'm joined again by Mona Johnson, who's a friend of the show, a GP, and someone who's been on before. And she's come on to talk about systems thinking again. So, Mona, do you want to tell us a little bit about yourself and what you're going to tell us?
Yeah, so I think more about me is kind of listed out all my jobs and all the rest of it on the other show. But I've been working basically in kind of digital health by accident, coming from what's called now transformation, but really is kind of about change and change management and implementation. And along the way, I think what I've got really interested in is why, when you have the right answers and you can see what the problem is, and everybody can see what the problem is, but you can't get change to happen. And so I've got really interested in what is it that makes people get stuck? How might you do things differently? And particularly, I think, from my perspective as being a doctor or for any clinician, really working with others to make change happen. And so most recently, I've been doing that in NHS England as we moved there from NHS Digital. And my kind of particular area and topic is about triage, which is a hot topic, I think, in everybody's minds, and how to do
Very
that better,
yeah.
differently. Yeah.
Yeah. So you've written a really good Substack, which I'd recommend everybody read. I'll put the links in. I'll also put the links to your previous episode, which is super interesting. And that Substack talks about another way to think about why things don't change that I felt was really helpful in unpicking the what is often misdiagnosed as just resistance to change.
Mhm.
And there's a lot more subtlety within that lack of change. And by drilling down into that, you can sort of find out what it is that's maybe holding back the thing that you need to improve and address it directly. I thought it was
Yeah.
really helpful. So there's a great framework that you've created there, and the threats. I think looking at where the resistance comes from and what the threats are. Do you want to go and talk us through the different kinds of threats that you've noticed?
Yeah. Yeah. So I think, I mean, what I've found is that, and I think probably this will feel familiar to a lot of people, is that systems kind of work in complex and complicated ways. And really, systems are a mix of lots of different things: processes, people, organizations, politics, context, all of that stuff. It's really complicated. But as you get used to doing something, it kind of settles down into a pattern of doing and into a kind of a groove. And we know where we are when we're in our groove. And even though it might be a bit uncomfortable, we sort of just keep doing it, some of us. And then someone comes along and says, "Hey, that groove looks really uncomfortable. Would you like to get out of it?" And there are some people that say, "No, it's familiar. I know what I'm doing here. And if I move, what does that mean about me?" So I think that's a kind of a key part of this, is that it becomes about those people and what it means. And the kind of the threats, as I've named them in my little Substack, are, in particular, I'm referencing and looking over here, so excuse me, like that one, intellectual. What if I'm doing this wrong? Like, what if this means I've been doing this wrong all along? And I think that's a really kind of personal thing and really hard for people to admit, that it might be that they're not quite doing things right. I
Yeah.
think we had this with, like checklists in operations and marking the leg and that you're going to chop off and all that kind of stuff. There was a lot of resistance to that because people thought, what does this mean about me if I'm not getting it right, if I need a checklist? Yeah,
Yeah.
so it's a kind of a really deep one that is quite tricky to overcome easily, I think.
Culturally, we medics put a lot of emphasis on being sort of knowledgeable and being right inherently in some way, like
Yeah,
that if you need an external system to help you be right more often, that's a failing.
yeah,
And it's obviously it's a hallucination. It's not at all a true thing, because we rely on all kinds of external things every single day, but we're blind to those ones, and so it's only the
Yeah.
new ones that we see. You know, like a checklist feels like it's something we should just know inherently and never need a
Mm.
checklist. And I think that some of the resistance comes from that, the culture of you should be right and you should know things.
Mm.
Whereas in, say, the airline industry, having a checklist before you take off is just so normal and so accepted that you'd be ousted for not using one.
Yeah. Yeah, and luckily it has gone that way now in medicine as well. And I think there's some really deep reasons why that's true in medicine, that we're kind of enculturated into this idea of we must be right. It's partly, I think, because if we didn't have that confidence, the things that we would be doing to people would be assaulting them and poisoning them. So I think it's kind of necessary to overcome something, but how do you find a way to soften back into uncertainty when that threatens your identity, all sorts of other things? So, yeah, it's a really big one, I think, in healthcare systems in particular.
Yeah, it's possibly not. We never really get any lessons, do we, in this meta medicine, which is the the psychology of you being a doctor. What is one
Mhm.
having to do? Because yeah, a lot
Yeah,
of what we do is would be illegal if it wasn't being done for the reasons of medicine,
yeah,
and um, and you know, everybody's also picked a persona. You know, there's the kind of very harumphing professorial doctor, and there's the kind of
mm,
um, helpful, squeaky type of junior. And you know, there are roles, or what you might call tropes. You know,
yeah,
that people adopt. I remember a very harumphing professorial type was the person who told me this. He was saying
mm,
everybody picks a style and becomes that style.
yeah. Yeah, and I think it is a kind of a role that we put on. And I'm as you're talking, I'm thinking, yeah, Dr. Johnson is quite different to Mona. So and I think having that kind of knowledge about yourself to kind of know that's a bit of what you're doing is also something that's important to recognize. Without it, we're a bit blind to the fact that, it's necessary. We need to put on a persona to be in our job. We are different with different groups of people and in different settings. And it's partly that the context is different. But and there is something that is, yeah, more kind of two-dimensional sometimes to our personas that we can be at work. And I think if we get confused between who those people are, that can be even more difficult. So yeah, it's that bit intellectual. My second one was interpersonal, like what does this mean for my role and credibility and my identity?
Well,
And
that
then my
meshes
third,
exactly with what we've just been talking about. You know,
yeah,
that's the challenge. Does it challenge my ability to continue being this actor,
yeah,
kind of doctor? You know.
yeah. Third on my list, I've got political, and in that is like ownership and control. And I think probably I read a really good book last year by Jim Easton that I've kind of called out in the Substack. It's called Obstructed, and I would really recommend it to anyone. It's a really nice, great read. I enjoyed it a lot. It's not a dense book. It's just like having a nice conversation with somebody, and they're telling you all of this stuff. But in that, it kind of calls out that in medicine in particular, and I don't know if you've had this, but there can sometimes be, my experience has been the resistance to me personally as a doctor has sometimes been about that role itself, and people thinking that as a doctor, I'm thinking I have more control or more say in this whole situation.
Yeah.
Um, and that gets even more complicated when you work in an organisation, as I do, like NHS England, or potentially the Department of Health. And what does it mean to be in those positions and be telling people about what to do? So, yeah.
I've come across that as well, and not really knowing where to place myself, having worked in NHSE and D in the
Mm.
past, and other organisations where it's obvious that no one else knows where to place me quite as well. So I'm maybe the only clinician in a team. Also, if because I write code and I am a developer,
Mm.
there is no ready-made box in which to put me, and it's quite difficult for people to know how much to trust what I'm saying, because I could just
Yeah.
be a sort of a bit of a Walter Mitty fantasist who thinks he can do these things. Maybe I am. How would we know? And so it becomes very difficult, and you can see people are sort of calibrating
Mm.
what's the political, where do I come in the hierarchy?
Yeah.
Am I the doctor that's in charge, or am I a clinician advisor, in which case I'm just to be asked a question, and you can ignore me if you want. Am I a developer? Am I writing the code? Am I steering this project? Do I have political clout? And I don't know the answers to some of those questions in some
Yeah.
circumstances, and that makes it difficult for people to sort of determine, particularly in a digital health scenario. We're talking about trying to create change in digital health,
Mm-hmm.
and you can see the barriers going up sometimes with people whose
Mm.
historical strength is threatened by clinicians coming into the space,
Yeah.
because they own the NHS's tech, don't they?
Mm-hmm.
Clinicians should stay in their lane and just go and
Yeah.
save lives,
Yeah.
and not get involved in the tech. And I'm saying the opposite. I'm saying, look, if the tech was any good, I wouldn't be here. I'd be saving lives. I'm here
Yeah.
because it's so awful. Now, obviously, if I put it that way, that's going to light up everybody's red flags, isn't it? But that is how sometimes it feels.
Yeah.
But obviously, that upsets people, because you're sort of saying that first intellectual resistance comes up. It's like you're saying we're doing it wrong,
Yeah.
and it's even, to some extent, it's even more complicated than that, because we're dealing with technology which advances quite fast.
Mm-hmm.
So we're not necessarily saying you've always been doing this wrong, you're bad
Yeah.
people, you don't know what you're doing. We're saying the technology has moved forward, we need to go with it in order
Yeah.
to be able to do it as well as it can be done now. But that isn't an indictment of the past necessarily.
Right.
I think the only failing there would be failing to recognize that things can be done better now and
Yeah.
things need to move on. And I think anyone who is using health technology day in, day out will recognize that things can be done better.
Yeah. And I think that, I mean, that feels really important that, I think in the old way of thinking about it, you implement your EHR, there you go, off you go, you're done, you've transformed digitally,
Yeah,
bish, bash, bosh, and next problem, please.
yeah,
But it just doesn't work like that for technology. And in digital health, I think it's about kind of creating the conditions where change can happen in an ongoing, fluid way. So you've kind of got to be in that mindset if you're running that kind of work, that change is just part of the experience of being here. So how do I create the conditions where we can continue to change and adapt and flow and move and have enough of that looseness in our system that we're not just wired down? And it's really hard to do because you get into contracts with particular suppliers that you can't get out of easily.
mm,
And using the thing means all of your stuff is and processes are tied up there, so you're going to have to do the whole thing over again. So yeah, it's really tricky, and like that takes me nicely to my next point, which is kind of operational. Like, is
yeah,
this actually going to work? Can we actually do this? Do we have the time and energy and capacity and people and all that stuff to kind of churn through this again? How do we keep this moving? It's going to take
100%.
time and money and all that stuff. Yeah,
That
so
is
hard.
that is always very high on the list of concerns that people have with any change. Some of the changes that we're asked to do, we know straight away are going to result in more work and everything taking longer, and we already don't have enough people, as it were, to
Mhm.
do the work that there is. And we know that because everybody is 100% maxed out the whole time. There's no slack in the system in
Yeah.
medicine. Um, whether there ever can be slack in the system in medicine is a philosophical point, I guess. But if we had limitless staff, would we ever get to the point where there was actually downtime and opportunity for reflection and
Mhm.
learning and understanding and
Yeah.
improving?
Yeah.
But yeah, people do worry. This change will result in our service grinding to a halt because you've broken something.
Yeah. And I think, that kind of, I mean, you doing me a favor here, like we're segueing into all my points. So, yeah, because the other one is about like, is it the right moment? Sometimes um, you can have an idea that's it's the right idea and it's the right solution, but it might just not be the right moment. So that bit of kind of being able to hold on to some of these things. I've had this for a very long time. I think I had some conversations with NICE in 2017 about digitizing or having a computable version of NG12, the 2 week wait referral criteria, and having some kind of means of capturing that information ahead of the consultation, or just having a kind of self referral process. And
Wow.
we do actually have that now in the breast. We've got a route 3111 for breast cancer or breast lumps. It is possible, but that was 2017. We're talking in 2026.
Yeah,
That's the kind of timeline you've got to be willing to be open to, I think.
it takes time, doesn't it, to seed an idea from this is kind of wild and out there into this is something we need, even though you were right in 2017.
Uh-huh.
If you'd had that conversation with them and said, in 2017 we should have a computable referral framework, you were right, but they weren't ready to hear it. And I think there's a lot of innovations and ideas that I think need to be brought in that they do require some of these organizations to actually take the leadership because they're the only people who can do it. So
Mhm.
NICE, the Royal Colleges, I've talked a lot
Yeah.
about, best practice as code from the Royal Colleges. Now, RCPCH is doing that, but it's the only one. And the other colleges will eventually arrive at the same destination. They
Mhm.
will
Yeah.
internally decide. And at that point, when they Google it, they'll find all my stuff. that's that's one of the reasons why I like open sourcing things, is that essentially
Mhm.
you're creating a library of ideas that are ready when the world is ready for them. Someone will Google it and they'll find it and they'll
Yeah.
come to you. So maybe that's one of the let's say a solution or a partial solution to some of this frustration is write it down. If you have an idea and you're just getting resistance because of any of these things, but
Mhm.
particularly the temporal one, um,
Yeah.
if it just doesn't feel as though people are ready yet, then
Mhm.
put it out there. Elaborate the idea as clearly as you can. Make it as easy as possible for people to get on board with it, um, and to learn what you mean and to play with it and understand it. And just
Yeah.
leave it there. Leave it out there on the internet. And eventually someone will
Yeah.
come to you and say, we want this.
Yeah. I kind of feel like it should have its own kind of website address called kind of Cassandra's, I don't know, something like place to put all of her thoughts. It's I think that frustration of thinking, oh, this is my experience anyway, that frustration of being kind of ahead and being able to see where we could go
Mm-hmm.
and feeling like why can't people hear me and why can't people come with me? And yeah, it's really tricky. But I guess the really great ideas do come around and have their moment. And, I'm nowhere near realizing my ambition yet of the NG12 stuff. But I do feel like my work is contributing to that path of getting there. And actually, it's that idea that has driven a lot of what I do, even though it looks like I'm working in a different field, working in triage. Actually, for me, it's about developing the blueprints and patterns that mean that we can kind of take that journey in different directions, vertically and horizontally. So yeah, it's yeah, we'll have to workshop a name for that website address, but yeah.
Yeah, I don't have the name for it. The nearest I have is on GitHub. There's these things called awesome lists, which are just
Mhm.
curated lists of good things in any particular field. And I've got an unawesome list, which is all the missing NHS things, which
Mm.
includes lots of these needs to be computable sort of requests.
Mhm.
So, like
Yeah.
the GMC register needs to have a private key and a public key, and you need to be able to sign things, and people need to be able to verify your public key on the GMC register, right?
Mhm.
That has to happen for us to get independently verifiable signatures in medical records and in prescriptions and things that works anywhere in the world.
Mhm.
That requires the GMC to take a leap forward in terms of its technical capability that it's not ready for.
Mhm.
That's one of the things on that on awesome list,
Awesome. I like
and
it.
uh, I think gradually it's a place to put these things, and eventually
Yeah.
somebody might see them and do something about them.
Yeah. So, well, we've come to the end of my list of threats, so we're on to the remedies now, if you'd
Well, that's
like.
good. Yeah, tell us about the remedies.
So I broadly can categorize them. I mean, it seems to me that I like prime numbers, apparently. So I can categorize them into three kind of broad groups. One is about like, how do we address stuff about ourselves? How do we address stuff about working with other people? And what do we think about that kind of system thing, creating this sufficient flexibility, or being able to hold flexibility and uncertainty within a systemic kind of frame. So I'll start with us, me, you, the
Mhm.
personal. Um,
First person.
it's yeah, first person. Yeah, and my first one really, which I think we both have talked about, the problem that being right isn't enough. That having the right idea, listing out the unawesomeness, it's just not quite enough sometimes. Sometimes it is enough, but I think there's something about kind of recognizing that even though in all other fields of our lives, and most people who go into healthcare have gone into it because they really want to get stuff right for people, they want to have the right answers, that that's kind of like what drives a lot of people here. But it's just that kind of recognition that this is really complex, and you haven't failed by having the right answer, but it not really kind of going anywhere yet. So I think it's kind of my one that I come back to, and has probably been the motivator for any of this work or development or examination of, why things don't land, why they don't take hold, and why they don't move on.
Yeah, yeah. So, number two, reflection isn't just for CPD. It's a
Yeah. Yeah, and I mean, we're doing this now, I guess, and I'm going to list this on my appraisal. So it's about having that kind of ability to look inside and think, what is it about me that I need to get stuff right? Where am I falling down here? What isn't going brilliantly with these other people? What
Mhm.
can I work on to make this a bit better? And how is it that I tend to operate in the world that runs me into trouble? And I kind of, yeah, sometimes I know what they are for me, and sometimes I don't. But one of the things that I have really noticed is that when I get frustrated, I can get really rigid in my mind about how I think about things. So it's really good for me to have other people to talk to, or take myself outside for a walk or something, or just to recognize, oh, I'm starting to get a bit inflexible here. What's going on? I think having that kind of self awareness of when you're starting to run into trouble can be a bit helpful, if only to kind of pull you back, because most of us will be flexible enough with others. But I think, I don't know, Marcus, do you recognize that in
Oh,
yourself?
yeah, massively recognise the kind of when you feel frustrated and trying to push harder, and it's just not it's actually not working, and completely taking your foot off the gas pedal at that point, and sort of moving away from that problem helps me.
Yeah.
I'm I sort of have the role of the sort of outsider. Really, I've always felt like I'm. I seem to find problems with things that other people seem to think are fine,
Hmm.
which I've had to come to terms with the fact that that's probably mostly me. And so I just go and find my own solutions to it. So
Hmm.
the great thing is that software actually is an area where you can do that.
Hmm.
So even if nobody else agrees that a particular thing is done badly, I can produce a software solution to it that works for me on my
Hmm.
computer. And uh, because of the way I work, I'm not clinical anymore, and that means I'm essentially free to do what I want. I would find it very difficult in a fully constrained full-time clinical environment.
Hmm.
I think back to how I was when I was working in hospitals, and found it everywhere, seeing problems and knowing that there were solutions, and but always finding that you couldn't fix them.
Hmm.
But I've managed to find a way of reflecting on that and just sort of moving away from it when it bothers me, kind of thing.
Yeah. I mean, I quite like that as a way of sort of thinking that the choices there are about, can I find a solution that works for me? Can I find something that works for me in this? Or do I need to kind of go into a different space? But also kind of recognizing the role that we can tend to play in groups, and where our familiar spaces are, being the outsider or being the person that's able to view critically, or if we're the sort of person that just wants harmony, wants to be super collaborative. So knowing yourself, like, and I don't think there's anyone that's particularly better than another, because we can't all be one thing. We need a mix, and that can be uh, tricky. But it's taking us into the, like, how do we do this stuff with other people? And so I've kind of named the next one as the F words. And for me, I don't know, what do you, well, I think it's about getting feedback, and sometimes through flattery. And I mean, it sounds a bit kind of pejorative, but um, taking the first bit of, like, having that little bit of humility of thinking, maybe I'm not sure why this isn't working, why this isn't landing with people, but maybe I could get some information from someone. And, some of the people who are most, let's say, threatened by change, let's say very kind of senior consultant in a hospital setting, and you go along with an idea about how to do something differently. Um, and there are two ways of approaching that I've found. One is to go with a fully formed answer and say, this is the answer, help me get it done. Or there's a different way to go, which is to say, I think I've noticed this problem. I think I've got some thoughts about it. I'd really like to get your feedback about how that might work,
Mm.
because I know you've been here for a really long time and you'll be able to see things that I can't see. And in that way, through kind of that's sort of flattery, if you like. It's a sort of, I feel a bit
Yeah,
manipulative and Machiavellian when I say it, but it's not done in with that intent. It is
I think
for me. Yeah.
it's kind of it's people skills, isn't it? It's knowing how to handle people, and I remember people talking about this in consultation skills that we learned in general practice
Hmm.
GP training. Um, the idea that people don't want to be told because
Yeah.
it puts all of their defenses up. But if you ask them, and then you've got to slip in the pieces of knowledge that you would like to include in the solution
Yeah.
in a way that they find palatable. And I
Yeah.
think some people are just naturally good at that. I know that I am naturally bad at that. But
I think you're better than you think, but I think I do actually. I think that we got a bit of a head start on this to a lot of our colleagues who've only ever worked in hospitals, because we did have to learn that, and it is a different skill in general practice, and that was the biggest learning curve for me. Was that shift from because I had that experience when you video yourself in consultation of just really losing the patient. Like they literally sat back and folded their arms and did this with me. But then being able to notice that that happened and go, all right, how do I do this differently?
mhm.
Yeah. So I think we get a bit of extra training in GP, which I don't know if they get in hospitals, but maybe is part of where this came from.
It's definitely not universal in hospitals. So there might be specialties that have introduced consultation skills type training, but
Mhm.
general practice is the only one that's really gone into it as a sort of cultural adoption. And we've got things like the Roger Neighbor and all that kind of stuff.
Yeah.
Those
Yeah.
consultation theory is not a thing. um, I'm prepared to be corrected if there's somebody who knows better than me out there. That's what the YouTube comments are for. But yeah, it definitely does help. The other thing that helps is, to some extent, being bad at it makes you have to think about it.
Hmm.
Whereas some people who are just naturally good at it, they've never thought about it because they've never had to. They
Yeah.
were born good at handling people.
Hmm.
Some people just have that emotional intelligence and that sort of people skills that they've just always had since a child.
Yeah. Well, I'm definitely the one that has had to learn it. So yeah,
Yeah,
and it is tough at first, but I think the other bit is that it will help. It will actually help you improve your idea. It will kind of sharpen it. Most ideas improve under pressure. Yeah,
yeah,
and so it's good to have the feedback and do that. So it takes me kind of to that like unlikely allies part, which is about having that kind of what I've called relational courage to sort of have those conversations to notice, something about, well, an example from my life is I'm really great with ideas. I'm really good at seeing where we should go. I'm not always brilliant of knowing how we can get there. I need people to come with me that are really good at doing delivery and completing, because completion is not really one of my top skills. I'm not good at finishing things. So I'm great at the start, but you kind of need to know this about yourself and be able to go out to the people who can do that. And often
yeah.
I find in a clinical world that can be your colleagues in management. They really know how to deliver stuff and get stuff done. And you can go to them and ask them how to improve your idea or what you'd need to do to get it landed. And they'll know about different structures and the different hierarchy that's in your organization that would get you to where you need to go, I think.
Yeah, I mean, working in some of the teams I'm working at the moment, it's been really helpful having people like product owners and service
Mhm.
owners and designers, user researchers, content writers, and everybody has these different roles. Um, and just when I'm starting to think, oh, there's too much going on, I can't actually keep it all in my head. I'm now in a sort of panic mode because I'm worried that
Mhm.
something's going to get forgotten. And then you realize there's a whole team and they're
Yeah.
really good at managing the complexity and keeping little incremental steps of movement. We're always going forward and there is progress and I don't need to panic.
Yeah.
And I can contrast that with other jobs I've had where um, they're a smaller team and not really the same level of project management.
Hmm.
Say it's that managers, project managers, program managers um, are very good at making things, getting things to the finish.
Yeah.
And even if, because of the way I think about things, if I can't get it all in my head, I start to panic.
Hmm.
But I have to remember that there's no requirement for me to get it all in my head
Mm.
because I'm just one
Yeah.
part of the team. Um, Maybe that's a clinician thing as well because we're trained we're trained to do sort of one to one, and everything is very, you're personally responsible for your personal practice, and the team working isn't the same as team working as everywhere else. If you
Hmm.
imagine working on a ward or an ICU or an A&E,
Yeah.
possibly A&E is actually the best example of a good functioning team, but a lot of medical teams are just hierarchy. That's
Hmm.
it. It's just who can you dump on, you know, all the way down the chain, to do to offload the most boring tasks in medicine.
Yeah.
Um,
Yeah. Yeah. I know that one.
Not
Yeah.
the same as having a functioning team where people have roles and respect.
Yeah. I think that's an important kind of aspect, like that collegiality, the respect, the kind of that we're all pulling in the same direction, and we've all got our own roles in that, and they add together to make it kind of more than the sum of its parts, if you like. Any single one would not be as good as everybody together. So yeah, but I think then I'm going on to my next one, which is getting into systems. And it's about having that clarity about the direction that you're pulling in, and being able to have that kind of golden thread that you're all sort of driving towards the same um, objective or endpoint. Because
That's
having
often
that,
a
yeah,
really difficult one to get everybody aligned on, isn't it?
yeah,
Because I think even in a group that thinks it's all there for the same reasons, if you really drill down, there can be quite a lot of variation between what people in each person's head, what they think that they're supposed to be doing and why they're doing it.
yeah. Well, I'm just remembering as we're talking, just recently they've come back from their moon mission, and
Oh,
the,
Artemis, yeah,
yeah, and the female astronaut who now I can't remember her name, but there was a little clip of her and she was talking about teamwork and being a crew and what makes a crew. And she said that about like we're all pulling in the same direction, but we've all got a slightly different, or the way I heard it was, we might all have a slightly different story about what that means, but we know kind of our big objective about where we're trying to get to. And, it's kind of all on the same mission. I think it's something about that. That's my dog. Sorry, shaking. Um, yeah, that's kind of the thing, isn't it? The nugget, the kind of where's your north star that you're all pulling towards, and can you tell that story?
mm.
I think when it's really clear, you can tell that story in a similar enough sort of way that it lands with other people and
Yeah,
starts to pull towards momentum rather than a kind of a fragmentation of where we think we're going, because then it starts to not be as effective as if we're all rowing at the same pace.
yeah. I think that the real challenge with technological development and digital health in that context is that you're trying to convince people that maybe a different technological approach would give them everything they want and more, but they can't see that because they're not technology people.
Hmm.
And so the example would be if we had the conversation with NICE to say, all your NICE guidance needs to be computable and it needs to come as programs that can be executed. And
Hmm.
those they should come with the terminology bindings that enable us to run that program over a record, extract the bits of the record via the terminology bindings, run the decision tree, and represent the outcome, put that back into the record, do take the actions and stuff.
Hmm.
Essentially, turning medicine into something that's programmable. Um, can you imagine having that call with the people who currently edit guidance at NICE? They're going to think I've lost my mind because
Yeah,
for them that sounds like not at all what they want to do. That it
yeah,
might they would say maybe that's something someone else should do when I've written a PDF, you
hmm,
know. But and we're trying to say no, we need to author this as the program and make the PDF out of the program, make the
hmm,
website out of the program,
yeah,
and make executable so everything comes from that upstream artifact, and that essentially lights up everybody's fears, because now essentially you're saying that they can no longer be an editor at NICE because they don't program. And that is where it's so hard to create that alignment, because
Mm-hmm.
we are aligned. They will still get their PDF. It'll be even better.
Yeah.
But medicine as a whole moves forward 2 decades
Yeah.
because of computable biomedical knowledge artifacts. And but I can't create a North Star with everybody on that line, if you see what I
Yeah.
mean.
I mean, I would say, yeah, I would go even one step further, which is the objective would be about creating a test and learn system that really tells us what guidance is effective, what the outcomes are if you use it, what they are if you don't, so that we can
Yeah,
update the guidance in real time on a regular
yeah,
sequence. And that means that we don't have to have committees working in the same sort of way. And we don't, yeah. So I think this is another workshop idea for us, but yeah, but
completely.
it's about, yeah,
It would
how do
become
you move
less.
people?
It would become less of opinion and expert groups and more about evidence. We'd be able
Yeah,
to say you could even test out different hypotheses in
yeah,
the guidance, and then within a short space of time have research prove that one type of approach was better than the other, and then immediately we can switch everybody to the better one. And
yeah,
it's evidence-based medicine driving our pathways and our recommendations and guidance and things.
yeah,
But very hard to get there. The North Star should still be, the thing you can always align everybody under is we want to make medicine safer, faster, and better quality,
yeah,
maybe cheaper as well. But and everybody will align to that. But it's the bit in between. Like, I'm suggesting that you have to actually radically change something that we do currently in order to get there. And it feels like what you're asking them to do, it's a local maxima problem, isn't it? You're asking
mhm,
them, they think they're at the top of the mountain and they can't see any better way. And you're saying you've got to go down this mountain entirely in order to get up the much higher one that's over there.
mhm,
There is no cable car, and they're, unless we can find a way of giving them the metaphorical cable car that does that, a way,
yeah,
a soft way of transitioning.
yeah. I think we
Speaking
can.
of soft ways of transitioning,
Um,
revolution or evolution, the next point.
yeah. So, I mean, I am a big proponent of evolution. I think incremental change tends to be the way that you turn the tanker. I think one of the things that Jim Easton describes in his book that I mentioned earlier is this kind of brinksmanship that we have in medicine. You know, we all know what to do when it's an emergency and we can kind of like really all dive in there. And I think it's that mindset that sort of drives this. We've got to just tear everything up and like start again. And it's, we've got to have this great big revolution. Revolutions tend to be painful and bloody in historic terms. So, is that really what we want? Or could we plan to get the same kind of outcome that you would get from a revolution through a process of evolution that takes us all on a journey? So, that's that. In terms of threatening systems, revolution threatens systems fundamentally. It says you're doing everything wrong, it needs to be completely different, let's start again. People tend to resist that with, it's antibody raising stuff.
Yes,
So if
fair
you
enough.
really want to get somewhere, evolution is going to be the way. Sometimes revolution is required. I'm going to say evolution is your best way through 90% of the time.
Yeah, I think I agree as well that, you can't throw away everything in any given system because it's all functioning, it's all got to do things.
Mhm.
Um, I think where there, there are maybe small revolutions that need to be had to
Yeah,
create the evolution. So, for example, we know that some of our software is bad. We know that some of the reason for that is the way we procure it. So a revolution in the way we procure, which to me
Yeah.
would be in source, in house, build in house, bring the clinicians and the developers together to work on stuff that we need, and open source all that stuff so that everybody gets that as well.
Yeah.
And that would enable us to deliver the little evolutionary steps forward that each of those pieces of software gives us.
Yeah.
So and the revolutions don't have to be huge. We're just talking about one organization. Stop your outsourcing contracts and start building things in house.
Yeah. I mean, I'm willing to, maybe it's kind of like these two things exist on a kind of continuum, and we almost like, well, what I was thinking is when people do exercise and build muscles, there's tiny little ruptures which make,
Yeah,
things repair and build better, and that's kind of how it works. So I can take that, like small revolutions to evolve over time. That
to
that will
build,
work for me.
yeah,
Yeah.
little muscle tears to build strength. Yeah,
Yeah. Yeah,
I
I
think
like it.
that's
Well, that just takes me to my kind of last point, which is that sometimes this is just all about timing, luck, alignment. So having the kind of discernment to work out where you are with things like the nice problem, you know, knowing that at some point, I think what we're describing about nice will happen. That is
yeah,
the way it's going. And so there might be something about being in the right place at the right time. I certainly found that with the project that we did about breast lumps. Um, yeah, so just being able to kind of catch hold of that moment if it's there, and also to kind of soften back from it and wait for the right things, put yourself in the right places. But
yeah,
eventually, it can just be a bit of luck, really, that makes that
yeah.
happen.
There's a lot of serendipity and just being having something. It's the availability heuristic, isn't it? If someone does a Google search and finds the thing that they need, and then suddenly that actually gets a boost and can become useful to people. Um,
Mhm.
and sometimes you just got to wait it out. I think at the moment, certainly almost the last 5 years, has been a very bad time for people with ideas of any kind, really, because if you didn't work at one of the mega suites or one of the big companies, then your ideas was essentially ignored. So we've had,
Mhm.
in terms of procurement policy, we've gone bigger and bigger and bigger since COVID, especially.
Mhm.
But we've also had total chaos at the level of the organizations. So we had
Mm.
NHSX coming to being, causing chaos because some people at NHSD felt that it was a land grab, same at NHSE. Then NHSX went away. Then NHSD went away. Now NHSE is going away. We'll be back to just Department of Health and Social Care. And all the ICBs have had a massive
Mm.
attrition. And the chaos that that has caused cannot be underestimated. No one has got capacity to think, and
Mm.
certainly not to start building forward and coming up with new ideas. I think there's a much a retreat into, look, we've just got to keep the wheels on. And I
Yeah.
feel really bad for everybody. There's been so much churn there. Um, but at the same time, time is marching on.
Yeah.
And we do have to make some of these changes. But the things tend to go in cycles. So there will come a point when all the churn has finished and the chaos has ended, and we can start to regroup and and think about the next decade of healthcare, or the next 20 years of healthcare in digital, the digital work we're all trying to get done.
Yeah. Yeah. And I think it's that bit, there is a lot of change, there is a lot of disruption. And out of that, sometimes good things happen. But yeah, I mean, I've always been the sort of person that thinks it's I've been the kind of the changing from within person, which is a bit of a funny place for me to be. And I can see the value of having people that are doing the change from outside as well. And given all of the things that have happened with ICBs, there's going to be more of those people now outside thinking about how we move forwards and bringing the skills into that kind of wider community as well. and it might change people's thinking. I think all of the changes that we've seen with AI, even over the last 12 months,
Yeah.
it's massively going to change things. So some of those things that were just ideas are going to need to be delivered, and maybe there will be the means to do that in the next, I don't know, upcoming 12, 18, whatever months. So yeah.
Yeah, there's been a lot of change in the NHS IT leadership, and I think there has been a new appointment. And I think the new person is from Home Office, so has governmental experience. That's
Hmm.
massive potentially. I think that's a really potentially exciting thing, that government IT, health IT are much more related than the corporate sector are related to health
Hmm.
IT. So that's hopefully a person who will understand the challenges and can do things differently. And as you say, there's lots of people who are going to have left the NHS as part of voluntary redundancy, but they won't leave healthcare and they won't leave digital health. Hopefully, a lot of them will
Hmm.
stay around working in other roles, and sometimes they can just be more effective in those roles because they're not burdened by the kind of dead hand of bureaucracy that does somehow, even despite the best efforts of some great people, we say our
Mm.
sort of political organisations and NHS's traditional organisations
Yeah.
seem to culturally inhabit that space of bureaucracy above all. So moving out into the more agile sector might make
Yeah.
it easier to get some stuff done. So
Yeah. But here's hoping. Yeah.
yeah, well, that's been a really good roundup of the problems, why things don't change, and some potential remedies and solutions as to what you can do differently. And some of it just comes down to timing and luck, as you
Yeah.
say.
Yeah.
Um, but hopefully that'll be helpful to some of the people who are trying to make things better in this space. I know it's been helpful for me just to read your Substack and to sort of get my head around, sometimes, Marcus, you don't need to, smash yourself into this immovable object at the speed of light. That's not going to make any difference at all. But wait 12 months and I might not need to push hard at all.
Yeah.
Sometimes it's just put things on a shelf, go do something else for a bit.
Yeah.
And that it certainly helps with the frustration, with with how I feel
Hmm.
about things not moving forward.
Yeah. And I think finding people to talk about, and I really like this channel for that. It's a lot of the people that have been down this road before, finding that community, the conversation. It's really important. So yeah, thanks for creating this space as well.
Oh, it's been a pleasure. I've learned a lot from people like yourself and others. Just in a way, that was one of the reasons I thought I've always felt like I actually didn't know as much as other people, and this way, people come on my channel and they teach me. So I'm benefiting from all their knowledge because they come here and they tell it to me direct, and the side effect is that everybody else gets that as well, which I really like.
Yeah.
Well, thanks, Mona, for being on again, and I'm sure that you'll be regularly back because you've got such a great way of thinking about these operational organizational challenges. So thank you once again.
Yeah. Thanks.